Well, hello and welcome. My name is Julia Priestley and I'm one of the joint CEOs of the BTF. I'm very pleased to welcome so many people, patients and healthcare professionals, to what will, I'm sure, be a really interesting session. Each week, the staff and volunteers at the BTF receive hundreds of questions from patients and families. And I think it's fair to say that there's probably an aspect of almost all of them which touches on thyroid blood tests. So when we began this series of webinars 18 months ago, we knew that this was a topic that we really wanted to cover. And for that reason, we're absolutely delighted that we're able to hold this evening's meeting with as fine a panel of experts as we could hope for. In a moment, I'll pass you over to Dr. Carla Moran, who's kindly chairing the meeting, and she'll be able to introduce the speakers to you. Carla is a professor of endocrinology at the Beacon Hospital in Dublin. And as well as having expertise in thyroid cancer and endocrine problems in pregnancy, Professor Moran has an interest in the investigation of unusual thyroid function, having directed a national referral service for patients in the UK before she worked in Dublin. I'm sure that many of you will have questions following the presentations, so please type them into the Q&A box on your screen, either during or after the presentations. You'll appreciate, of course, that the speakers will only be able to answer very general questions. And as ever, if you've got specific concerns about your own health, then please do speak to your own doctor. We might not be able to get through all of the questions in the time we have, but if your question is missed, you're very welcome to contact us separately after the webinar, and we'll do our best to answer them. And just before we start, a plug for the BTF. If you do enjoy this webinar, please consider making a small donation to our charity, and this will help us continue the work we do, and in particular to provide more events like this in the future. I think that covers everything, so now I'll hand you over to Carla.
That's great. Thank you very much, Julia. So it's wonderful to see so many people have dialed in to this webinar, and I'm really pleased to be able to chair it and to take part in it. So interpreting thyroid function tests is, I can safely say, it's probably one of our favorite topics between myself and Krish and David. And we spend many hours each week looking at unusual thyroid function tests and thinking about what might be going on. So it's a real pleasure to introduce both of our speakers. I'll give you a little bit of background to both of them. So Dr. David Halsall is a clinical biochemist and he works at Addenbrooke's Hospital in Cambridge. David has very extensive experience in clinical biochemistry, and so he is based in the laboratory there, and he oversees the performance and analysis of thyroid function tests, and he's a real expert in looking at the laboratory aspects of interpreting thyroid function tests. Professor Chatterjee is a professor of endocrinology and also works at Addenbrooke's Hospital in Cambridge. And Professor Chatterjee is a world-renowned expert in thyroid disease. He has particular research interest in looking at thyroid hormone action. So that's how thyroid hormone works within the cells themselves. And aside from the fact that he has lots of research experience, he also has plenty of experience in looking after patients with thyroid disease. And he, like me, also has a particular interest in interpreting unusual thyroid function tests. So I think that we have two experts who are really well placed to go through the interpretation of thyroid function tests. So I know Krish and David are going to have a joint presentation, and that will last for about 25 or 30 minutes. And then we'll have a Q&A session after that. And I'd really like to encourage you to put forward your questions. We very much welcome your questions and we want to be able to answer them. And please do ask any questions you would like. So I think I'll hand over to Krish now to start his presentation.
So thank you, Carla, for that kind introduction. And thank you again to the BTF for the opportunity for us to speak. So I'm going to share my screen and then hopefully go to full screen. And I hope everybody can see that. So to start off in very general terms, thyroid hormones, the thyroid gland in the neck secretes predominantly about 80% T4, and to a lesser extent, the active hormone T3. And together, these hormones exert various effects on our organs that I've illustrated here. Now, imagining that I'm speaking to a largely adult audience, I haven't dwelt on the very important effects of thyroid hormones during the development of a baby or in early childhood. But I've summarized here some of the things that it's important for in adult life. So we know that various aspects of brain function, increasing heart rate and the contractility of the heart, something called metabolic rate, which in turn translates into body weight, our body temperature and energy levels, controlling the density of bones, how well our intestines contract, and then lowering cholesterol. And this cartoon also reminds me to say that actually, in terms of measuring the effects of thyroid hormones on all these organ systems, we don't really have any good laboratory markers for these endpoints. So we actually rely principally on this particular blood marker called TSH, which I'll talk about in a minute. And then the main diseases that we consider and want to think about are overactivity of the thyroid gland due to a condition called Graves' disease, which is the commonest cause, 1% of the UK population, where antibodies stimulate excess production of thyroid hormones. And then conversely, a destructive process called Hashimoto's thyroiditis, where the thyroid gland is destroyed by the cells of the immune system, and that leads to low thyroid hormone levels and thyroid underactivity, and that probably affects about 3% of the UK population. Looking at the production of thyroid hormone in a bit more detail, as I said, cells in the pituitary gland secrete a hormone called TSH, which we can measure in the blood. That stimulates the thyroid gland to produce T4 and T3. T4 is what we call the prohormone, and under the influence of enzymes expressed in lots of tissues called deiodinase enzymes, it gets converted into T3, the active hormone, and it's the active hormone which then exerts the physiological effects that I showed you in the previous slide, working inside cells via molecules called receptors, and I won't dwell on that. An exquisite relationship that we're aware of is a feedback relationship whereby the T4 and T3 that are produced by the thyroid gland circulate in the bloodstream, and then they inhibit this hormone TSH, and here higher up in the brain, another hormone called TRH, and thyroid hormones via this negative feedback process control their own synthesis. And as a preamble, when we want to diagnose overactivity of the thyroid gland, hyperthyroidism, we do these blood tests, one or more of them, typically the TSH all the time, but then maybe the T4 and the T3 to go with it. And if we see this pattern, that is hyperthyroidism, and conversely in hypothyroidism, the TSH is elevated and T4 and T3 are low. And I'm going to pass over to David, who's going to tell us more about this T4-TSH relationship. David.
Yes, you've heard from the professor about the central role of TSH in this relationship. And I think it's reflected in a lot of guidelines who, not without contention, but TSH is down as the first test. And I think we can justify that, particularly from a lab point of view. We've got very good assays for it. We can measure it very reliably. But in a way, we're using the pituitary as a biosensor for thyroid status. So we're using our own pituitary to form a readout. And what the pituitary does is effectively amplify the signal. So if free T4 is dropping just a little bit, heading towards hypothyroidism, there's a massive change in TSH. So the pituitary's done the job of multiplying the signal up for us. And likewise, the other way, once the thyroid starts to become overactive, TSH is really, really quickly shut down. So we get this sort of logarithmic relationship. And if you look in the bottom panel, just to make it a little easier to see, we've stretched out the axis and linearized it. But by looking at the axis, you can see small change in free T4, big change in TSH. So provided you have an intact pituitary axis, it's a very good readout. There are situations when this doesn't apply, and we can talk about that as we go through the talk. But in general, TSH is a very reliable marker for thyroid status. So that was the theory, where you saw one nice line down the graph. This is the reality. So my own lab does about 1/3 thyroid function tests a year. It really is, in a way, we've been a victim of our own success, because we've developed highly automated methods to measure TSH now. So you can see roughly this logarithmic linear relationship, straight line between free T4 and TSH, although there's a wide degree of variation about that. And what we do when we send reports out, as I'm sure you're well aware, is we report them against a reference interval, which is shown here in green. Prof, if you can advance it. So most of the samples we see fall within the reference interval, and then you can see that the patients where the TSH is high are moving towards a hypothyroid state, shown in blue, and a hyperthyroid state, shown in red. Prof, if you can advance. So in general, we've got this log linear relationship, which provides a very good diagnostic fingerprint.
Yeah. So the hypothyroid in blue, and sorry, the hyperthyroid in red.
Yeah.
Okay. So I thought, moving on then, how better than to start off with a case? So a 34-year-old lady who's had palpitations and shaking of her hands, and her sleep's disturbed, and she's got a fast heart rate. And here I'm showing you the laboratory measurements that we made, which show that she has a raised free T4 and a raised free T3, and the TSH is suppressed. So David again is going to tell us then, based on that picture, which suggests hyperthyroidism or thyroid overactivity, what the next logical tests would be to do.
So yes, on this diagram, we've introduced 3 more players here. As Prof's already said, most thyroid disease is autoimmune disease. So when the thyroid is destroyed by the body, we can generate antibodies against thyroid molecules. So anti-TPO is something we commonly measure, which shows there's been a destructive process. So it's not particularly specific, because it'll be present in both hypo and hyperthyroidism caused by immune destruction of the thyroid. But on the other side, the TRAB, the TRAB is one of those great markers in the lab. We love it when we come across molecules like this, because this is the cause of Graves' disease. So as we can measure, it's a really good marker. So if you're hyperthyroid, TRAB will unequivocally say whether this is due to Graves or not due to Graves. I've also put reverse T3 down at the bottom, because there were some questions about it, and that I think should be very much left to the discussion part of the talk, because we wouldn't routinely advocate this measuring reverse T3 for any of the thyroid conditions at present.
And just to then amplify what David has said about those 2 different antibody tests. So in thyroid underactivity, we like doing the TPO antibody test, the anti-TPO antibody. We do recognize that 10% of the healthy population who don't have an underactive thyroid can have positive anti-TPO antibodies. But in hypothyroidism of the autoimmune variety, about 3/4 might be expected to have positive antibodies. Conversely, in thyrotoxicosis, due to an autoimmune process, Graves' disease, this antibody test, TRAB, which, if you spell it out fully, stands for anti-TSH receptor antibody. This is a very specific test, as David says, and it can be positive in over 95% of people with Graves' disease. So these are the 2 tests that we favor in the 2 different forms of thyroid dysfunction. And for completeness, but I won't dwell on this, you can also measure antibodies against another protein called antithyroglobulin. It can be useful in thyroid underactivity, but it's not as good as anti-TPO. So actually, speaking from my own clinical practice, I don't find this useful in diagnosing thyroid underactivity or overactivity, and I would use these other tests. Okay, so moving on to our patient then. So having shown you the thyroid hormone levels, we then did measure this entity called TRAB, which is abnormal. So we've made a diagnosis of Graves' disease. And at that point, we would start treatment with antithyroid drugs. Here I've shown carbimazole. Again, I'm not going to get into the details, just to illustrate how we use the pattern of tests to guide the management of this patient with Graves' disease. So we would treat with a dose of carbimazole for a specified length of time, typically about 4 to 6 weeks. And at the end of that, we would expect the T4 to normalize. The T3 has almost normalized. And then we're in a position to reduce the dose of carbimazole. This is one way of treating Graves' disease, which is called the titration regimen, where we reduce the dose to a lower level. And then after a specified time interval, we do the tests again, and we aim to maintain the T4 and T3 in the normal range. Note that the TSH continues to remain suppressed, and in the discussion, I can explain why that is. Here, purely in this idealized scenario, I've shown that after a particular time interval, several months, shall we say, I have measured the TRAB antibody again, and the levels are coming down. That is not to say that I would advocate measurement of TRAB every 3 or 4 months. I would actually minimally only suggest that you need to do it at the beginning and at the end of a course of therapy. So we keep going, and after a further time interval of several months, we can see the same picture, and the TRAB is coming down, and then we're halving the dose of carbimazole again. Thyroid hormone levels remain normal, the TRAB is coming down. And then at the end of this course of therapy, perhaps a year or 18 months, we can talk about that. What we might ideally expect to see is that the TRAB has either gone down to a low level or become negative, and the TSH, which was suppressed for a long time, has flipped to become detectable and then now back in the normal range. And if reached this happy state, we might be in a position to stop treatment. Okay, so that's Graves' disease. Sticking with the theme of thyroid overactivity, I want to talk about a lesser scenario, a scenario where the blood tests are in the hyperthyroid range, apparently, but the patient doesn't have any symptoms. So here the clinical story is of a 65-year-old lady who's got no symptoms. She's got chronic lung disease, chronic obstructive pulmonary lung disease in the background, for which she's on inhalers, and she also takes prednisolone. On one occasion, we measured a TSH which was subnormal. Several months later, the TSH has become frankly suppressed. And then about 9 months down the road, the TSH is suppressed, and now the T3 has crept up and it's become elevated. This is a typical picture of evolving subclinical hyperthyroidism. And the way we investigate and manage that is shown on the left-hand side of this slide. So again, a patient starting off with a subnormal TSH, and then eventually the T4 and or the T3 become high. And typically that pattern of blood tests, particularly in individuals who have that pattern and have negative thyroid antibodies, particularly the TRAB antibody being negative, the likely cause may be one or more overactive nodules in the thyroid. And that's the second most common cause of thyroid overactivity, toxic nodular goiter. Very importantly, you might not see that progression. What you might see is a TSH which is subnormal, but then when you repeat it some months later, it has normalized. And that, by and large, in everyday clinical practice, is by far the more common scenario. In fact, it happens 3/4 of the time. And what might be imagined then? Well, it could be something called non-thyroidal illness. For example, if that patient had had an intercurrent flu or viral illness, that can affect the TSH. And as they get better, it normalizes. It can be drug therapy, and steroids, prednisolone, can inhibit TSH production, so it can produce that picture. or it could be iodine exposure. And if, for example, this lady, on account of an exacerbation of her lung disease, became very breathless and she came into hospital and had a scan, a CT scan, they might give her contrast, which contains iodine, and that could cause the TSH to become low. So a lot of the time, it isn't often subclinical, and we recognize the picture reverts. However, if the TSH remains chronically suppressed, we would continue to follow that individual and keep measuring the T4 and T3, looking to see if they're going to go down into this path. They might not, particularly if, and this is what I would do, if I would advise that patient not to take any iodine containing supplements that you can buy in a health food shop, because we know that if your thyroid is in a subclinically altered state, if you feed it the substrate for thyroid hormone, iodine, that can make things worse. If the TSH remains completely suppressed, and again, I won't dwell into this, we might then eventually investigate for other risks of subclinical hyperthyroidism, like low bone density or cardiac problems. David, over to you again to talk about TSH and other measurements in a lot more detail before we go into thyroid underactivity.
So we could dive a little bit deeper into the reference interval, and this is something that, you know, I know there's a lot of questions about this, and it's a really simple concept, but it's one of my bête noires that I think it's generally overinterpreted and can lead to a lot of anxiety. So really, it was a concept that was introduced by a geneticist called Ronald Fisher way back in 1913, and I think a lot of things you measure in biology form this pattern, which is called a Gaussian or normal distribution. So 60% of the people are about average, but only really 1 in 20 people stick outside the average. So Fisher's idea was this is where you're likely to find the abnormals, if you like. Pretty much that's all it is. You take a distribution like TSH and you say 1 in 20 people is likely to have a TSH which is unusually high or unusually low. Now that's all it is. It's not a diagnostic threshold. It's not a treatment aim or goal or any sort of cutoff. It's just the distribution of TSH in a reference population. So if we move on, Prof, I think you'll all be familiar with blood pressure. Blood pressure forms this Gaussian distribution. And I think we're also aware that some people have high, some people have low blood pressure, and this isn't just a nicety of biology. We know that we can treat this, and it provides benefit, provides health benefits by looking at this. So this is the concept. So if we move on one more, Prof. So this is how we do it in the lab. If you want to make a reference interval in the lab, the first thing you do is try and recruit 300 healthy volunteers. One of the benefits of working in the lab is you end up giving a lot of blood samples to these sorts of experiments. But already you can see there's a problem, because you have to define who goes into your reference cohort. And typically you're not going to include people who've got frank thyroid disease. But this can become a sort of circular argument in a way, because if you look at this distribution here, there's 272 people in it. By definition, 13 of these people will fall outside the reference interval. That's the way Fisher described it. So you're then faced with the fact that these people might have thyroid disease, in which case you need to exclude them, and then the reference range gets tighter. So it's a slightly muddy concept, and it should be treated with the respect it deserves, I think. It is simply a description of a population. So then you need to ask the question, well, why are people's TSHs quite so different? And I suppose our major fear in the lab is that we're introducing variability into these things. We know that whenever you measure anything, you introduce error. So we're particularly careful to make sure that the laboratory is not responsible for that wide range of results. So this is something all NHS labs have to do and want to do. This is our external quality control. So what happens is a single sample is sent to all of the NHS laboratories or any other laboratories that are are in the scheme, and we all measured the same sample and we all send the same result back, and generally the case is we all get the same answer. Certainly for something like TSH, no matter where you send your sample, I think you can be reasonably confident that you're going to get the right answer. If you're not using an NHS lab, I think you're perfectly within your rights to ask to see some sort of assurance that the laboratory you're using is doing some sort of external quality assurance. So the other thing, so it tells us as a lab that we're probably doing okay, but we also use different methods to measure. These are supplied by external providers, and there are 4 main kit manufacturers in the country. And you can see for TSH, there's not very much difference between the different providers of TSH assays. So this is a sample with a value of around 1.8, and everybody gets pretty much the same answer. So I think one of the questions we were asked is, why do labs have different reference intervals? And I think for TSH, there's probably not much of a reason to have different reference intervals these days, because everybody's measuring the same thing. So wherever you send your TSH, you should get pretty much the same answer. Unfortunately, free T4 is much harder to measure for reasons that the 3 of us could spend the rest of the evening talking about, but we'll spare you the discussion. But the long and short of it is that free T4 will depend on which manufacturer you're using. So the reference ranges are not interchangeable. If you're using, if you look at this slide here, if you're using the Beckman method, you get a result of 13. If you're using the Roche method, you're getting a result of 16.5. They're not interchangeable, and you'd expect that to be reflected in the reference interval, which indeed it is. So when you're looking at your own free T4 results, make sure that it's with an appropriate method-dependent reference interval. Okay, so whilst we're introducing a tiny little bit of variability, the majority of variability is coming from biological variation. And we know TSH changes with age. Again, it was a question that we've been asked. TSH tends to go up the older you get. And also in young children, your thyroid gives you a big kickstart when you're born. So you get very high free T4s, which slowly drop into the adult ranges. But outside extremes of age, the TSH reference interval is relatively constant. So I think this is possibly the most enlightening slide I have. This was a wonderful study that was done quite recently, where somebody took 20 healthy volunteers and just repeatedly measured their thyroid function test 3 times a day for the course of a month. And the dotted lines show our reference interval, which we're all familiar of, about 0.4 to 4. And you can see that people do have variable TSH measurements, but they're slightly lower than the reference interval. So you're likely to run your own TSH within a tighter limit than the reference interval. And it's also not, they're also distributed fairly widely across the reference interval. So Prof, if you can highlight, yeah, the sample you're looking at there, we've got one that overlaps the reference interval. So there's someone who runs a higher TSH than most people. They're more likely to get a diagnosis of hypothyroidism if they have the thyroid function checked, or maybe they're on their way to developing hypothyroidism. But the principle here is that you probably have you do have your own set point for TSH. So this leads to problems with diagnosis as to when you're given a diagnosis of hypothyroidism or not, but also when it comes to treating people with hypothyroidism as to where you should be aiming for, and that depends entirely on your own set point. There's a debate as to where you need to have your where your TSH needs to rest when you're being treated. So there's a lot of debate and an awful lot of literature on optimizing reference intervals for TSH. And to be honest, I'm not sure that any more torturing of the TSH reference range is going to help, because what we're trying to do is, what we need to know is what's TSH in people who benefit from treatment. So we need to look at TSHs in people who are hypothyroid, the people who need treatment. So no amount of looking at normal individuals is going to do this. So moving away from the 1931 hypothesis, we're now using something called the odds ratio. I think anybody who does horse racing will get this. So you look at the ratio of the normal results from a healthy person compared to what you might expect in somebody with hypothyroidism. And this gives us two cut points. The first is the value of 10, which appears in all the guidelines. And this is a specific cutoff. There are very few reasons for having a TSH greater than 10, apart from being hypothyroid. So we're reasonably confident here that this is the group of patients who will respond to treatment. On the other end of the scale, at a value of about 2.5, you're extremely unlikely to benefit from thyroxine therapy at this sort of level. But in the middle, unfortunately, there's this area of uncertainty, and rather tragically, our reference range sits in the middle of it. So if you have a TSH on the reference range, this is the least informative number. And I guess at this stage, the test doesn't really help you. And it's a conversation with your doctor about whether you're likely to benefit, whether you're not likely to benefit, whether you have signs and symptoms. At this stage, the test isn't really going to help that much. So we need to have a continuous approach rather than this fixed cutoff. A TSH of 3.9 is no more hypothyroid than a TSH of 4.1. It's just unfortunate that that's the way they often get reported in lab reports. Prof, maybe you can put some clinical context on that rambling.
Okay, so that was very helpful, David, and I'll try to pick up the key points that you talked about and how this operates in clinical life. So frank hypothyroidism. So to start off with things that are not controversial or less controversial. So the first thing to say is that as this destructive process causes more and more of the thyroid tissue in the gland to fail, TSH climbs up way above 10, and for a certain period of time, you may be in a compensated state where your T4 keeps falling further and further down, but your body is desperately trying to maintain synthesis of the pro-hormone, the active hormone T3. And so that stays within the normal range. But eventually, when the thyroid completely packs up, both the T4 and the T3 become quite subnormal, and then therapy, of course, is instituted. And here I've just shown that when one institutes thyroxine therapy, your first aim is to normalize the TSH, and with that, you can normalize the T4 and the T3. However, for most people, they may never have had a thyroid function test done before they ever developed a thyroid problem. So we don't really know what your individual set point is. So it is true to say that I don't know whether to keep the TSH at 3.2 or at the 5 end, or bring it down to the 0.35 end. Before I deal with that, I might be confronted, and you might be confronted with this scenario, which is a few months after you had this blood test, you're still on the same dose of thyroxine, but that next blood test comes back abnormal with a higher TSH. And I won't get into a long chapter and verse on this, but suffice it to say that this could happen simply because at that particular moment in time and in the days and week or two leading up to it, not enough thyroxine was getting into the body, either maybe because you missed a few doses of thyroxine, or you had a gastrointestinal disturbance or something, and the thyroid hormone wasn't being absorbed properly. And it can give rise to a single sort of aberrant picture. And if I saw this on just one occasion, I wouldn't act on it necessarily. I would just say, okay, let's let a few more weeks elapse. And then if you repeat the test, you might get back to that picture. Going back to this question about how much thyroxine one should then give, it's generally based on a formula that's body weight related, but one might also be guided by an individual's symptoms, and eventually one might titrate the dose up, because one doesn't know what the set point is, to achieve this sort of state. So my hypothetical patient with hypothyroidism at this point in time might say, look, I'm feeling absolutely fine. I'm feeling perfect on this. And I, as the physician, would be comfortable with that because I know that the TSH is within the normal range. It's at the low end, but it's not subnormal or suppressed. And in a small group of patients, when that happens, I might not even be perturbed by the free T4 being slightly above. The TSH is okay, the free T4 is slightly above. I would measure a free T3 in that situation to check that that is normal. And again, in the discussion, I can go into the reasons why that might happen. Now, based on the science that David has shown, which is that the TSH in healthy people is not always in the same interval between that 0.35 and 5, and that people, the healthy people over the age of 75, long life equates with a TSH which is at the higher end, maybe 5 or maybe even up to 7, perhaps it's acceptable in an older patient with hypothyroidism to run them with numbers that look like that. And I'll say no more. Okay, moving on from frank hypothyroidism then to what we call subclinical hypothyroidism. Now, here's a typical scenario of how this might evolve. So at the first point in time, one records totally normal thyroid hormone levels, including TSH, but a very strongly positive TPO antibody titer, suggesting that that individual's thyroid is likely to undergo this progressive destructive process. And if that occurs, then at some future point in time, could be months or even a year or two down the line, the TSH has risen. And then if you go further still to a third later point in time, the TSH hits this threshold of 10. And this is on the continuum of what one might define as subclinical hypothyroidism. And again, I'm paying tribute to the work of Mark Vanderpump and Mike Tunbridge many years ago, who studied this at a population level. What they found is that if you have positive antibodies, then you're likely to progress to developing hypothyroidism at that sort of percentage. If you have a slightly raised TSH at the top end, again, you're likely to progress. And if you have the two together, the combined risk of progression is much higher. And it's this evidence that really guides how we approach individuals with abnormalities in this direction. So if you have a TSH which is at the top end of normal, slightly above 5, we would always measure the antibodies. And if they're strongly positive, as I showed you in that idealized case, the two things, you're strongly likely to progress to hypothyroidism. Why not start some thyroxine therapy now? If, however, the antibodies are negative, you might just opt to watch and wait and repeat the blood tests. If then the TSH rises to above 10, then again, thyroxine therapy could be started. If, however, you're in that gray zone between 5 and 10, it's very legitimate if you've got absolutely no symptoms to go down this path and just keep measuring the TSH at 6 monthly or a yearly intervals, again, avoiding iodine-containing health supplements because they could aggravate the picture. On the other hand, if you have got symptoms, a trial of thyroxine is warranted, and if it's beneficial, one could continue. Importantly, it's worth saying that if the symptoms are not benefited by thyroxine, then in my opinion, what your physician should be doing is actually asking the question, could there be other things that could be causing the symptoms, for example, tiredness, and really delving deep to exclude the possibility that it's not linked to thyroid. So we're going to go away from hypothyroidism with that. And in the very last slide, I'm just literally for completeness going to talk about what we do with thyroid function tests in individuals with thyroid cancer. So in thyroid cancer, the gland has been removed with a total thyroidectomy, and people have sometimes had radioiodine on top of that. And the thyroid cancer doctors can now grade people with thyroid cancer into categories of low, intermediate, or high risk. And that's a process called dynamic risk stratification. And when they make that risk assessment, what they tell us to do as endocrinologists is to adjust the dose of thyroxine to keep the TSH within certain boundaries that they specify. Now, why do they do that? They do that because in addition to TSH stimulating the normal thyroid, theoretically, TSH can stimulate the growth and proliferation of microscopic potential remnants of thyroid cells that have been left behind in the neck, microscopic remnants. And so if there is that potential that TSH is a growth factor for thyroid cells, then you might want to switch it off if you're at high risk, and as I'll show you. So if the risk is very low, if you've had a low risk cancer, then the dosage of thyroxine one might give is to maintain this sort of picture. On the other hand, if it's an intermediate risk, we might give you a slightly higher dose of thyroxine in order to keep your TSH between that sort of range. And if it's high risk, we would up the dose of thyroxine to completely suppress the TSH. At that point, you might be running a T4, the pro-hormone, which is above the upper limit of normal. But importantly, if I do the T3, usually that's reassuringly within the normal range, albeit at the upper end. So with that, I think we're done in terms of what we wanted to say. We're a little bit over time, 5 minutes or so, but I think I'll stop there, and we'll take questions.
Great, thank you so much, Professor Chatterjee and Dr. Halsell. They were really great presentations, and I think provided a lot of information for patients. So there have been a good few questions that have come through. And if you do want to ask any questions, please do pop it in the Q&A. We'll try to answer as many as we can. So there have been some themes for the questions coming through. So some people have asked about, maybe, Krish, this is one for you, about the TPO antibody positivity. Should we be repeating it? If we do repeat it, if the TPO antibody level goes up, does that mean anything? What would you say to that?
I think the short answer is probably not. I think we recognize that there are grades of positivity. And again, I haven't burdened you with the sort of hard numbers, but in that typical hypothyroid case in our laboratory, over 1300 is very, very positive. And then there's a middle range, and there's a low positive range. Those antibodies are actually a imperfect marker of what's happening in the thyroid. Those antibodies are not the things that are destroying your thyroid tissue. But what's destroying the thyroid tissue are the cells of the immune system. And of course, we can't see into that. And that's one of the reasons why I would argue that repeatedly measuring that antibody is of little value.
Okay, David, maybe if I direct the next question to you. There's a good question, I think, about whether TSH varies with race or ethnicity, and a similar question about whether it changes in terms of the time of the day or the season.
So yeah, the answer to both of those questions is yes. I think the question regarding ethnicity may depend a little bit more on factors like iodine concentration in the area that you live in. There's a well-described circadian rhythm of thyroid hormones, so they're slightly higher in the morning than they are in the afternoon. So maybe 2.5 in the morning becomes 2 mid-afternoon, and then back up again. And there's also a seasonal variation in TSH as well. It's it's a hibernation hormone, and the temperature will change it. But based on my discussion around the variability, I think there's not much to be gained by having increasingly sophisticated reference ranges for TSH, given the overlap. I don't think there's too much to be gained by teasing it apart in its minutest detail.
Okay, thank you. So there have been a few questions. I suspect maybe both of you will have an opinion on this. A few questions about persistent TSH suppression, either in the context of somebody's been thyrotoxic for a while, maybe due to Graves' disease, and they have looked at their blood tests and they know that the TSH is persistently low. They've seen that. Or perhaps, I think there was a question of somebody maybe who might have been on T3 and their TSH is persistently suppressed. Okay. So any discussion about that?
So maybe I can take the Graves' disease one first, because I did point that out. So indeed, this is an unusual phenomenon. And the truth is, we don't exactly know why the TSH stays chronically suppressed. I can give you two possibilities. One is that when we measure the thyroid hormones in the blood, it's a snapshot in time. It's not the T3 level, let's say, throughout the 24-hour period. And one possibility is that in that patient with Graves' disease, the snapshot T3 measurement is okay, but over a 24-hour period, the gland is producing just a shade too much T3, and that accounts for the persistently suppressed TSH. Another explanation, for which there is also very good evidence, is that the receptor to which TSH receptor antibodies bind, strangely enough, is also expressed on the TSH producing cells of the pituitary. So there is a suggestion that the Graves antibody, the TRAB, is the one that binds to the pituitary cells and shuts off your TSH for a long time. As I said, there's scientific evidence for that too. I think, Carla, you would agree with me that in clinical practice, we just observe this as a phenomenon, that when we treat a patient with Graves' disease for months, the TSH can remain suppressed, and then as things are getting better, it flips. Mm. Yeah, and then the second half was to do with T3.
Well, it was kind of similar, really. You know, being on T3, and people have noticed that their TSH is persistently suppressed. And a question kind of related to that of, you know, if I'm on T3 and my T3 is high and my TSH is suppressed, are symptoms such as palpitations and so on related to the low TSH, or are they related to the raised T3?
Okay, so so my take on this is to think about it in terms of the feedback axis. So actually, when it comes to suppressing the TSH, the pituitary gland is sensing a combination of the T4 and the T3 in the blood. So it senses the T3 in the blood directly, because that gets straight into the cells and is the active hormone. But the pituitary cells also sense the T4, because that gets taken up and it gets converted via these deiodinases to produce extra T3 inside the cells, which you can't measure, and together that suppresses the TSH. So to me, for me, the arbiter is that the TSH is suppressed. And if the TSH is truly suppressed, what I rely on is a body of evidence which shows that in the healthy population, individuals who have a chronically suppressed TSH are at greater risk of low bone density and cardiac problems in the future. And if you were to extrapolate from that finding to patients on thyroid hormone therapy, and here I don't distinguish between T4 or T4 and T3 in combination, then I would argue then that in the long term, that's may not be a good place to be. Mm-hmm. T3 blood measurements in people on T3, it's problematic because T3 is a very short-acting hormone. And so we know that when you take a dose, the level in the blood is greatly influenced by the timing of the blood test in relationship to when you ingested the T3. And that's not the case with T4.
Mm-hmm. Okay, thank you. David, there has been some questions about what the optimal way from a patient point of view to measure thyroid function tests. You know, should they be done fasting? Should they be done at a particular time of the day? Does it matter?
Again, depending on how exacting you're going to be, I suppose having a 9 o'clock blood test would give a degree of continuity to it, but that's not that straightforward. I wouldn't see it's a particularly big issue. I don't know what you think, Prof. Does it? TSH is going to change slightly, but the overall picture, I don't think is going to be greatly influenced by what time of day you have the test done, or whether you've eaten or anything like that.
I think, as I say, in one of the early slides, I showed that TSH is a hormone that has what we call a very long half-life, so it moves quite slowly, and so a TSH measurement is not going to be influenced by when you took the thyroxine in relationship or in relationship to the blood test. The free T3, as I said, is influenced, but then and again, I can amplify on this if people want. In people on combination therapy, I still look primarily at the TSH, and then I look at the T4, T3 relationship in order to judge the balance between the amount of T4 that I prescribe and the amount of T3 that I prescribe. I don't look at the absolute value of T3 or absolute value of T4 in judging the balance of combination therapy, and particularly not T3 for the reasons that I've talked about.
Okay, great. So there has been quite a few questions and comments about maybe weight gain following treatment for thyrotoxicosis, whether that's Graves' disease with antithyroid drugs, or whether it's, following radioiodine treatment. Do you have any comments on that or any advice for patients?
Yeah. So, okay, I think this is an interesting area for research, and patients may well have their own view on this. When an individual is thyrotoxic, we know that they lose weight, and it was an oversimplification to suggest that that weight loss is because your metabolism has sped up. What also happens unquestionably is that the high thyroid hormone levels act on the appetite centers in the brain, and they stimulate one's appetite. So it's very well known that when you're thyrotoxic, you've got both things going on. You can eat an awful lot more, and yet you're burning off the energy, and so you're losing weight. And I think what happens when you correct that is that balance between the appetite and the energy expenditure is out of sync. So your resting energy expenditure normalizes quite quickly, but your brain, which has been fooled into sort of overeating, this increased appetite, that takes longer to adjust. And so in some individuals, you may then get an overshoot where you're still consuming more energy, but you're expending less, and then that leads to weight gain. And then, as in any individual, thyrotoxic or otherwise, we all know once you put weight on, it's very, very hard to shift it.
Yeah, it is. I agree. It's a real clinical problem, one definitely for more research, something that bothers patients quite a lot, I think, understandably. There have been a few questions really about people having persistent symptoms. So perhaps they are on treatment for hypothyroidism, their TSH is perhaps within the reference interval, but they still have symptoms. And we see this quite a lot clinically. Do you have any advice for what those patients should do?
Yeah, so I can only give you my opinion, which is my personal approach here. And I would, as the audience would know, this is a contentious area, and it's an area where more research is needed. So the first thing to say is that not knowing what an individual's set point is, I would, as I showed you in that example, be able to titrate the dosage of thyroxine upward to bring the TSH down to the lower end of the reference range. I wouldn't easily subscribe to, or I wouldn't subscribe to a suppressed TSH for the reasons that I've stated earlier, because that carries with it health risks. But keeping a TSH at the low end may eliminate those residual symptoms. If they don't, I think it's worth asking the question whether there are other causes of ill health, and investigating thoroughly for that. And then, which is the area that requires further research, with residual symptoms that are particularly in the neurocognitive domain, there may be evidence that combination therapy may have a role to play in alleviating that. But I do think formal clinical trials are needed in order to show that, in order to change global practice on a wider basis.
Mm-hmm. Thank you. David, there's been a few questions about thyroid hormone tests during the menopause and whether the menopause affects TSH, T4 levels. Do you have any comments to make on that?
Again, I don't think there's an established relationship. I don't think the biochemical of thyroid hormones will be affected by the menopause.
Okay, great, thank you. So I'm just going through to make sure that we've answered most of them. So a few questions on kind of research, whether there's any research going on in Cambridge on Hashimoto's thyroiditis, and whether there's any new treatments coming through for Hashimoto's thyroiditis.
Gosh, yes, that's that's an unexpected one. No, I have to say we aren't researching Hashimoto's thyroiditis, and I say that because I guess historically we've explored other areas like rare genetic causes of thyroid overactivity or underactivity right across the ages, I should say, from birth, which is my colleague Nadia Schoenemacher's, through to adult life. And then, as Carla has said, one of our other enduring passions, if you like, is, which is an equally important area, is investigating why the measurement methods sometimes get tripped up, all the various causes, because I do believe that that's an equally important problem in day-to-day practice. As David has said, and our hospital is not unique in this, there are hundreds of thousands, in fact, 10 million thyroid function tests done a year. And if even a tiny proportion of those are erroneous or artifactual, there's an awful lot of time and energy that people can waste going down those blind alleys. And we think we can make a valuable contribution by sifting through some of those bear traps.
Mm-hmm. Great. And maybe time for two other questions. So, David, there's been some questions about whether there's a problem converting, for some people converting T4 to T3. Do you think that that's something that we see, or what you know, often we see in people who are on thyroxine that their T4 seems to be a little bit higher and their T3 is a little bit lower. Do you think that means they're not converting, or is it a thyroxine effect?
So I think I'd go back to Prof's initial discussion around this, that I would take TSH as being the best marker here, and the T3, T4 ratio. I'm not saying there's no benefit of changing T3 to T4. I'm just saying at the moment, our measurements of it cannot help direct that sort of therapy. You don't want TSH, in simple hypothyroidism, you wouldn't want TSH to be too far away from the reference range. If you want to change the ratio of T3 to T4, then yeah, maybe if it works, but there's nothing we can do by measuring those two hormones at this stage which would say you should alter the ratio of T3 to T4. I mean, it's a very common finding, as you know, Colin, in people on treatment T4, that the T4 runs slightly higher than it would in people not on T4 therapy. But currently, I don't think there's a therapeutic intervention in that group of patients.
Okay, great. Thank you very much. So I think we've kind of covered the topics that came through in the questions. There was just one question that I just want to highlight. Somebody wrote in who it seemed like they had thyrotoxic symptoms after previously being treated for Graves' disease. So just wanted to make a comment that Graves' disease can recur in 1 and 2 individuals who've previously had Graves' disease. So if you have thyrotoxic symptoms, I'd recommend getting your thyroid function tests performed just to make sure that it hasn't come back. But other than that, I think we've covered the topics. So thank you very much for your interaction and for everybody putting in your questions. I'm going to hand over now to Julia, who's going to wrap up the session.
Julia, I think you may be muted.
Oh dear, I'm very sorry about that. Thank you very much to the 3 of you for really excellent and fascinating session. We all knew that thyroid function tests aren't easy to understand, but I think you've all helped us learn a little bit more about how they're used and what they can tell us. And it's been so interesting to have the clinical context alongside the biochemistry explanation. So thank you for that. We're not used to having that level of detail presented, so it was really interesting. And thank you to everybody who asked such great questions as well. I really enjoyed the explanation discussion about set points, and I'll certainly take that being one of my take homes from today. If you joined the session late, or there are any bits that you'd like to go back to watch again, then we will be adding a recording of the session to our website, so keep an eye out for that. And you can also see previous webinars on our YouTube channel. If you've got any further questions, or you feel that your own question wasn't answered, again, you can send those questions to us, and there's an email on the screen. There's a lot more information about all aspects of thyroid health on our BTF website, and we'd love it if you'd like to join BTF if you're not already a member, and to support our work that way. So once again, thank you so much to our wonderful speakers, Professor Chatterjee and Dr. David Halsall, and to our excellent chair, Professor Carla Moran. We know how busy you all are, and we really are very grateful that you found the time to speak to us tonight. And a huge thank you to everybody who joined the session to listen and to ask questions. Please stay in touch with the BTF, and we look forward to seeing you at future events. Thank you. Good night.